Very happy to welcome all the audience back. Let me quickly announce that if you have any questions, please feel free to leave a message and our moderator will help you to present the questions to the speaker. And in our next section, very honored to welcome Professor Yasuhiro Izumiya to give a speech about diagnosis and treatment of cardiac amyloidosis in Japan. And we are also very honored to welcome Professor Wu Yanwen from Far Eastern Hospital to be our moderator.
Thanks for the introduction. I'm Dr. Wu Yanwen from Far Eastern Memorial Hospital. Currently, I'm also the chair of the Nuclear Cardiology Committee. So it's my pleasure to introduce the next section. As we know that cardiac amyloidosis is a very important disease. Before the treatment developed, I think it's many cardiologists think that it's a hopeless disease. However, more and more treatment options develop, and the most important thing is that nuclear studies can help us to quick diagnosis of the disease. So it's our pleasure and honor to have the lecture. Let me introduce briefly about the Professor Izumiya. Dr. Izumiya is graduated from Osaka City University School of Medicine and then finished the training and also got a PhD of the pharmacology in 2004. Currently, he moved to development of cardiovascular medicine, Osaka City University. Actually, this year, our Taiwan Society of Cardiology has invited him to have a lecture to all the cardiologists in Taiwan, and we are very inspiring about his talk. So this time we ask him again to come to our society to talk about the guideline in Japan. Let's welcome.
Okay. Thank you, Professor Fu, for your kind introduction and the kind invitation. 皆さん、こんにちは。My name is Dr. Izumiya from Osaka City University. I will talk about the guideline on diagnosis and treatment of cardiac amyloidosis in Japan. What is cardiac amyloidosis? Amyloidosis is defined as organ dysfunction due to deposition of beta-sheet structured amyloid fibril in multiple organs. Cardiac involvement is the most significant predictor for poor prognosis in patients with systemic amyloidosis. Cardiac amyloidosis is a progressive infiltrative cardiomyopathy characterized by restrictive cardiomyopathy and presentation with conduction system disease. Systemic amyloidosis is divided into several types depending on the context of amyloid fibrils. Several amyloidogenic proteins cause systemic amyloidosis. However, not all amyloidogenic precursor protein is deposited in the heart and exacerbates cardiac function. So the first part of my talk, I would like to talk about what kind of cardiac amyloidosis that cardiologists often encounter. In the clinical setting, we cardiologists mainly encounter two types of amyloidosis, including amyloid light chain, AL amyloidosis, and transthyretin amyloidosis, ATTR. At first, I will talk about AL amyloidosis. AL amyloidosis is caused by deposition of amyloid fibril derived from misfolded light chain of monoclonal immunoglobulin generated from abnormal plasma cells. So the underlying disease is multiple myeloma, primary macroglobulinemia, or monoclonal gammopathy of undetermined significance. This slide shows the recommendations and levels of evidence for blood testing for suspected cardiac amyloidosis. If we suspect AL amyloidosis, we should measure serum immunoglobulin and serum and urine immunofixation, and serum free light chain. In addition, we should measure high sensitivity cardiac troponin and BNP or NT-proBNP because the prognosis of patients with AR amyloidosis is highly dependent on the involved organs and the severity of organ damage, especially in the heart. This slide shows the revised Mayo Clinic staging system is generally used for the predicting prognosis in patients with AL amyloidosis. In this staging system, patients were assigned a score of 1 for each difference in free light chain, cardiac troponin T, and NT-proBNP. Next, I will talk about transthyretin amyloidosis, ATTR. What is transthyretin? Transthyretin is named from its function, that it binds and transfers thyroid hormone and retinol binding protein with vitamin A. TTR is mainly produced and secreted from liver and much lesser extent in brain and retina and pancreas islet. TTR is stable in bloodstream if it forms tetramer like this. However, in the case of genetic mutation or aging, TTR tetramer becomes unstable, developed misfolded monomer, ultimately developed as amyloid fibril, especially in the heart and peripheral nerves. Dissociation of TTR tetramer is considered as a rate limiting steps of ATTR. Depending on the presence or absence of genetic mutation, ATTR is divided into two types. The first type is the presence of genetic mutation, hereditary ATTR, also called ATTR-V, formerly called familial amyloid polyneuropathy. The second type is wild-type ATTR, which is absent of genetic mutation, formerly called senile systemic amyloidosis. First, I will talk about hereditary ATTR, mutant type ATTR. Amino acid substitution in TTR promotes amyloid fibril formation by destabilizing TTR tetramer. VAR30MET is the most common genetic mutation in Japan, preferentially causes neuropathy dominant phenotype like this, so also known as familial amyloid polyneuropathy. Despite neuropathy dominant phenotype, cardiac involvement is observed in about a half of VAR30MET FAP patients. Relatively rapid progress in conduction disturbances and atrioventricular block rather than wall thickness and heart failure are characteristics of VAR30MET FAP patients. Next, I will talk wild-type ATTR. Upon aging, amyloid fibril derived from wild-type transthyretin monomer are gradually deposited in multiple organs, especially peripheral neuron and heart. The symptom of ATTR wild-type emerge in patients aged over 60 years. Therefore, ATTR wild-type was called systemic senile amyloidosis. The prognosis of ATTR wild-type was thought to be better than other type of amyloidosis. However, it's not so good, as revealed by the median survival after diagnosis was reported 43 to 47 months, like this. Also, ATTR wild-type has been thought as a rare disease. However, the frequency is higher than expected in elderly population. A recent study showed that in patients with heart failure with preserved ejection fraction, 13% were accounted for by ATTR wild type. Aortic stenosis is also observed in older patients with left ventricular hypertrophy. Transiting cardiac amyloidosis is prevalent in 16% of patients with severe calcific aortic stenosis undergoing TAVI. This paper showed prevalence and outcomes of concomitant aortic stenosis and cardiac amyloidosis. Concomitant pathology of AS cardiac amyloidosis is common in older patients with AS and can be predicted clinically. AS cardiac amyloidosis has worse clinical presentation and trend toward worse prognosis unless treated like this. Here's a medical treatment, and here's an AVR treatment. Therefore, the author concluded that TAVR should not be withheld in AS cardiac amyloidosis. So, early diagnosis is very important, both AL amyloidosis and ATTR cardiomyopathy, because disease-modifying therapy is remarkably progressed and available in Japan. So the second part, I will talk about latest disease-modifying drugs for cardiac amyloidosis. At first, I will talk about tafamidis. Tafamidis bind to the thyroxine binding site of both variant and wild-type transthyretin with high affinity and high selectivity, like this. This inhibits dissociation of tetramer into monomers. That is the rate-limiting step in the formation of transthyretin amyloid. Tafamidis is the first pharmacotherapy approved to slow the progression of peripheral neurologic impairment in patients with ATTR polyneuropathy. However, its effect on ATTR cardiomyopathy has not been elucidated. To address this issue, a ATTRACT trial was conducted, and 70 patients were enrolled from Japan. And in this trial, I was a principal investigator of Kumamoto University. This table shows the baseline demographic characteristics. Mean age was 74 years, and about 90% were male, and about 75% were ATTR wild type. Baseline characteristics were generally similar for treatment group. This figure shows the Kaplan-Meier analysis of all-cause mortality. As you can see here, 30% reduction in the risk of all-cause mortality with tafamidis compared with placebo. And as you can see here, the separation began at about month 18. This slide shows the pre-specified subgroup analysis. Please look at here. The reduction in all-cause mortality and frequency of cardiovascular-related hospitalization were observed only in NYH class 1 or class 2, but not class 3. Following the result of ATTRACT trial, ATTR cardiomyopathy was added to the indication for tafamidis in Japan. This slide shows the recommendations and levels of evidence for tafamidis for ATTR cardiomyopathy. Class 2A recommendation is for the patient with NYHA class 1 and class 2, whereas class 2B indication for the patient with NYHA class 3 in Japan. RNA interference, RNAi, is an endogenous mechanism for controlling gene expression. Patisiran is a hepatically directed RNAi therapeutic agent to reduce the production of mutant and wild-type transthyretin. Apollo trial is a randomized, placebo-controlled phase 3 trial involving patients with ATTR variant to assess efficacy and safety of patisiran treatment. As you can see here in the patisiran group, the reduction in serum transthyretin level was rapid and sustained. Patisiran significantly improved neuropathy in patients with hereditary transthyretin amyloidosis like this. Based on these results, patisiran was approved for ATTR variant polyneuropathy in Japan in 2019, but not yet for ATTR cardiomyopathy. So our interest is patisiran effective for ATTR cardiomyopathy. To address this issue, the effect of patisiran on cardiac structure and function was evaluated in a pre-specified subgroup of Apollo patients with evidence of cardiac involvement at study. The number of patients is 126, and pre-specified subpopulation is baseline left ventricular wall thickness equal of over 13 millimeters, and no history of hypertension or aortic valve disease. This slide shows the result. Patisiran reduced mean left ventricular wall thickness compared with placebo at month 18, like this. Patisiran also led to increased endodiastolic volume and increased cardiac output compared with placebo. Patisiran also lowered NT-proBNP at 9 and 18 months, like this. A reduction in event rate of about 50% for all-cause hospitalization and mortality, and about 45% for cardiac hospitalization and all-cause mortality. So these results suggest that patisiran may halt or reverse the progression of cardiac manifestation of ATTR variant amyloidosis. So as I mentioned before, early diagnosis is very important, both AL amyloidosis and ATTR cardiomyopathy, because early therapeutic intervention can improve prognosis of the patients. So the final part, I would like to talk about how to find cardiac amyloidosis patient at an early stage. Many patients with cardiac amyloidosis, especially in ATTR wild type, have a history of carpal tunnel syndrome. A diagnosis of carpal tunnel syndrome is supported by positive Warren test and Tinel sign. The progression of carpal tunnel syndrome can result in atrophy of acinar eminence, the inability to create a perfect O sign like this. Here is an interesting paper published in JACC 2018 showing that of 98 patients, 98 carpal tunnel syndrome patients enrolled, about 10% has a positive biopsy for amyloid. Then among them, 2 patients were found to have a cardiac involvement despite no cardiac symptoms. This slide shows the clinical symptom and laboratory findings suggesting ATTR wild-type amyloidosis. As you can see here, in addition to carpal tunnel syndrome, spinal channel stenosis and tendon rupture is also characteristic findings of ATTR wild-type. As I mentioned before, high-sensitive troponin T is useful biomarker to find cardiac amyloidosis. Serum high sensitive troponin T level was significantly higher in patients with cardiac amyloidosis group, especially AL amyloidosis. Among three types of cardiac amyloidosis, high sensitive troponin T level was highest among patients with AL amyloidosis than those with ATTR wild type and ATTR mutant. This slide shows the ROC analysis of the diagnostic accuracy of cardiac amyloidosis. When the cutoff for high sensitive troponin T level was set at 0.031 nanogram per milliliter, the sensitivity and specificity for diagnosing cardiac amyloidosis based on left ventricular hypertrophy were 74% and 76% respectively. It is widely known that low voltage in electrocardiogram, despite left ventricular hypertrophy in echocardiogram, is characteristics of cardiac amyloidosis. However, these characteristics are not specific in all types of cardiac amyloidosis. For example, low voltage pattern is a characteristics of AL amyloidosis, but not ATTR. On the other hand, conduction disturbance is frequently observed in patients with ATTR. So this table shows the rate of electrocardiogram findings among different types of cardiac amyloidosis in Japanese guideline. As you can see here, atrial fibrillation is more frequently observed in patients with ATTR. Echocardiography is an essential screening modality for cardiac amyloidosis. Not only LVH, but also right ventricular hypertrophy and atrial septum hypertrophy are characteristics of cardiac amyloidosis. Granular sparkling appearance has been reported in several studies. However, the sensitivity is not high with this pattern, which is seen only in 30% of cardiac amyloidosis cases. Apical sparing is a pattern that longitudinal strain in the basal and mid segment of the left ventricle is more severely impaired than the apical segment. Apical sparing is an early recognizable and accurate means of differentiating cardiac amyloidosis from alternative cause of left ventricular hypertrophy. So the main topic of this presentation, the scintigraphy that can detect calcium, has been proposed to be a useful screening tool for cardiac amyloidosis more than 30 years ago. However, it has been ignored for a long time due to the lack of specificity. However, the discovery has been made in 2013. Bone scintigraphy is extremely effective for detecting ATTR cardiomyopathy, but not AL amyloidosis. Based on extremely high diagnostic specificity, diagnostic algorithm for patients with suspected cardiac amyloid cardiomyopathy is proposed. If the patient who have heart failure, syncope, or bradyarrhythmia with echocardiogram and or cardiac MRI suggesting or indicating cardiac amyloidosis, bone scintigraphy should be performed. If the cardiac uptake equal to or greater than bone, that means grade 2 or grade 3, and excluded AL amyloidosis by using free light chain, diagnosis of ATTR cardiac amyloidosis is acceptable. To determine ATTR variant or ATTR wild type, TTR genotyping should be performed. Using bone scintigraphy, this study aimed to determine the prevalence of ATTR cardiac amyloidosis in patients with heart failure with preserved ejection fraction without left ventricular hypertrophy. In patients with heart failure with preserved ejection fraction without cardiac hypertrophy, 5.2% were positive for transthyretin cardiac amyloidosis. This paper is from UK National Amyloidosis Center showing that natural history of ATTR cardiomyopathy and compare outcomes among patients with ATTR. The number of patients new diagnosis of ATTR cardiomyopathy each year stratified by genotype are shown in this graph, which highlight the recent rise in identification of ATTR wild type, as you can see here. 2012 is the year that bone scintigraphy was routinely introduced into the diagnostic algorithm for ATTR cardiomyopathy at National Amyloid Center. Survival of patients diagnosed with ATTR cardiomyopathy from 2012 was significantly better, as you can see here, than among patients diagnosed with ATTR wild-type cardiomyopathy pre-2012. These data indicate that bone scintigraphy led to an upsurge in early diagnosis. There are two methods for assessing Peyronie's bone scintigraphy, visual and quantitative assessment described in JCS guideline. Both of these methods are based on anterior planar images. However, adding SPECT imaging is recommended because it enables a more accurate assessment of uptake in the myocardium and blood pools. The cardiac uptake of the PYP has been demonstrated to be associated with prognosis. A heart and contralateral ratio over 1.6 was associated with worse prognosis among patients with ATTR cardiac amyloidosis. So this slide shows the recommendation and evidence for nuclear imaging for cardiac amyloidosis in JCS guideline. Diagnosis of ATTR cardiac amyloidosis with PYP scintigraphy is recommended as class 1. However, it should be noted that cardiac uptake of bone scintigraphy does not reflect transthyretin itself. So JCS guideline stated that although much remains unknown regarding the mechanism of uptake of pyrophosphate and other bone tracers in ATTR amyloidosis, it is suspected to be calcium mediated. So we should understand the limitation of bone scintigraphy for diagnosis of cardiac amyloidosis. The first limitation is that mild degree of tracer uptake is observed in less than 1/3 of cases with AL amyloidosis. The conclusion of this study is that while DPD scintigraphy is confirmed to be useful to differentiating TTR from AL-related amyloid cardiomyopathy, diagnostic accuracy was lower than previously reported due to mild degree of tracer uptake in about 1/3 patients. This table shows the positive bone scintigraphy in patients with AL amyloidosis. This paper also showed that about 51 AL patients with cardiac involvement had DPD cardiac uptake. This study assessed the frequency and degree of cardiac DPD uptake and its clinical significance among patients with AL amyloidosis. This large cohort of patients with AL cardiac amyloidosis, about 39% has cardiac DPD uptake, and patients showing cardiac DPD uptake showed a trend toward worse prognosis, as you can see here. And even grade 3 uptake is sometimes observed in patients with AL amyloidosis. This case report emphasizes the importance of screening of AL amyloidosis, even in patients with typical PYP scintigram findings suggesting ATTR. So diagnosis of ATTR should not be established without histological evaluation in cases with abnormal AL screening. The second limitation is false positive. This case report showed an 85-year-old man with increased thickness of ventricular walls and a positive bone scintigraphy like this. However, Congo-red staining and immunohistochemistry of left ventricular samples scored negative for amyloidosis. The final diagnosis, he was diagnosed with sarcomeric hypertrophic cardiomyopathy at left ventricular endomyocardial biopsy. So again, endomyocardial biopsy is highly recommended for the correct diagnosis of cardiomyopathy with hypertrophic phenotype. This case report also showed that a patient who is the hydrochloroquine-induced restrictive cardiomyopathy showed hotspot of bone scintigraphy in the heart like ATTR cardiomyopathy. But again, his diagnosis is not ATTR. Diagnosis is hydrochloroquine-induced restrictive cardiomyopathy. And the third limitation is false negative. This case report showed the bone scintigraphy was negative, as well as Congo-red staining on myocardial tissue sample. Given the high clinical suspicion, immunoelectron microscopy was performed and showing transthyretin amyloid fibril deposition that confirmed the diagnosis. So we should understand imaging modalities sometimes could be misleading. This review article described that accurate use of cardiac scintigraphy for the diagnosis of ATTR cardiomyopathy. Positive PYP does not always reflect ATTR. Please always screen AL amyloidosis. Positive PYP sometimes reflect blood pool uptake, so please always perform SPECT. And negative PYP, but not clinical suspicion persists. Please consider tissue biopsy. This slide shows the JCS guideline. In JCS guideline, tissue biopsy is necessary to diagnose cardiac amyloidosis, even if PYP scintigraphy indicate highly positive possibility of ATTR. So finally, I would like to talk about cardiac MRI. At present, rate gathering enhancement imaging in the most reliable methods to identification of cardiac involvement in amyloidosis. The characteristics of cardiac MRI in patients with cardiac amyloidosis is including global subendocardial LZE, right ventricular and left atrium LZE often appear, and dark blood pool. There is a significant correlation of LZE with clinical, morphological, functional, and biochemical markers, facilitates the evaluation of the prognosis of cardiac amyloidosis. What does LGE reflect in cardiac amyloidosis? LGE corresponds to the intestinal amyloid deposition and subendocardial fibrosis caused by ischemia due to capillary obstruction by amyloid deposits. Recently, T1 mapping is recognized as useful for quantitative assessment of myocardial tissue characterization and is currently recommended for diagnosis cardiac amyloidosis. Here is a representative image of T1 mapping in patients with cardiac amyloidosis and hypertensive heart disease. Native T1 and extracellular volume demonstrate abnormally high value in patients with cardiac amyloidosis compared to hypertensive heart disease. T1 mapping detects lesions with greater sensitivity than those LG imaging. Therefore, its use may aid the early diagnosis of cardiac amyloidosis. This slide shows the recommendation and evidence of cardiac MRI in patients with cardiac amyloidosis. Cine MRI and LGE imaging and T1 mapping are recommended as class 1 indication for patients with cardiac amyloidosis. Here is a very important review article published in JACC Heart Failure in 2019 showing how to screen ATTR in everyday practice. There are 8 red flags, including apical sparing, discrepancy between left ventricular thickness and QRS voltage, atrioventricular block, and the presence of increased left ventricular wall thickness, and intra-atrial septum and right ventricular hypertrophy, and MRI findings, and polyneuropathy, and carpal tunnel syndrome, and mild increase in troponin T. If we find these red flags in patients with heart failure and increased wall thickness over equal and over 40 millimeter, we should perform bone scintigraphy to screen the ATTR cardiac amyloidosis. If the patient who have these red flags and a non-invasive diagnosis approach, including bone scintigraphy and free light chain screening, should be performed. So this is the last slide, take-home message. It has been apparent that cardiac amyloidosis is one of the major causes of heart failure, especially in elderly heart failure with preserved ejection fraction. Recent progress in disease targeting strategy enable cardiac amyloidosis is treatable or curable disease from hopeless disease. So the clinician needs to suspect and identify cardiac amyloidosis patients as early as possible. Thank you for your attention.
Really, thanks, Professor Izumiya, for your comprehensive and inspiring talk. As a privilege, I would like to ask a question for our audience. As you mentioned that there are many image modalities could be helpful to diagnose cardiac amyloidosis, including echo, CMR, as well as the PYP scan. Is there a recommendation for the sequence of the image test?
Recommendation. As I mentioned in the summary slide, if we patient have only one red flags with left ventricular hypertrophy, we should perform bone scintigraphy, including PYP or DPG. Yes, so
okay.
we need to check the red flags.
In your talk, there is a very interesting case that a false positive case, because as we see that the PYP uptake is very strong, but however, the biopsy was negative. So how do you think about the possibility? Because as we know that the guidelines suggest that the grade 2 or 3 positive, the diagnosis of the cardiomyopathy is very high. But how to explain that your case?
Actually, it's not my case, but so the important point is no one knows the mechanism of why bone scintigraphy uptake in the heart in patients with cardiac amyloidosis. So we don't see transthyretin itself by bone scintigraphy. So there are some mechanism that mediate calcium mediated mechanism. So that's why the disease with impaired autophagy and impaired apoptosis disease might deposit calcium in the heart. In that case, bone scintigraphy should be positive. So in Japan, is guideline, and we Japanese clinicians always perform endomyocardial biopsy to diagnose cardiac amyloidosis.
Sometimes so we know that endomyocardial biopsies have risk, especially for the elderly fragile patient. However, the cardiac amyloidosis, especially the wild type, the patient might be very old and fragile. How do you think about if we get tissue proof from other side, not from the cardiac?
Okay, in that case, patient, in older patient, as you know, as you mentioned, endomyocardial biopsy is relatively high risk. So in that case, the patient with bone scintigraphy is positive. In that case, we usually perform the abdominal fat biopsy or gastrointestinal biopsy. If the tissue biopsy demonstrates that transthyretin positive, the diagnosis is acceptable in Japan.
The last question, I think it's a very practical question because as we know that treatment for the ATTR-CM is very expensive. How do you think about the treatment benefit for the patients, especially for the wild type? Because as we know that in Japan, it's an aging society. It's also in Taiwan, more and more aging people may have the problem of the heart failure and caused by the wild type amyloidosis. How do you suggest for the very expensive therapy for this kind of population?
Yes, cost of the drug is very problem also in Japan. But the effect of tafamidis was clearly demonstrated in the ATTRACT trial. So we think even if the patient is very old, but the patient's activity of daily life is very good, we prescribe tafamidis. But the patient with very frail old patients, we usually do not prescribe tafamidis. So the activity of daily life and frailty is very important.
Because time is limited, let me ask that very simple but maybe practical for new care physicians. Do you use the PYP scan to follow up the patient, especially for the patient, early onset disease or after treatment? How do you think about it?
Yes, it's a very important point. PYP could detect very early stage of cardiac amyloidosis without heart failure symptom. In that case, we performed PYP follow-up every year. And when the patient show the heart failure symptom, we think about the performed biopsy and to diagnose the cardiac amyloidosis. So bone scintigraphy is also useful to screening very early stage of cardiac amyloidosis.
Okay, really thanks for your excellent talk. I believe audience just like me, are very have a great, fruitful, inspiring from your talk. Because the COVID-19, you don't have the chance to visit Taiwan. We hope maybe next year we can see on site and face to face,
Yes,
and then
I
we
hope
can
so. I want to go to Taiwan next time.
Yes, I would like to behave out of our society and give your our grateful thanks. Thank you again.
Thank you very much. ありがとうございました。
ありがとう。